With Novo Nordisk, and I'm here essentially so my background, I'm in the market access department, previously health economics. I'm here to present the long-term cost effectiveness analysis for once weekly semaglutide comparing to once weekly dulaglutide in a dual therapy setting in type 2 diabetes and from a Danish healthcare payer perspective. So essentially the objective or the aim of this study was to project the long-term outcomes of diabetes, complications and quality of life using the core diabetes model, a validated model to perform this type of computer simulation modeling. We used the results from the SUSTAIN 7 trial, which compared 2 doses of semaglutide, both maintenance doses, 0.5 milligram, 1 milligram, compared to 2 doses of dulaglutide, 0.75 milligram and 1.5 milligram. However, for this analysis, we just used the results for the 1.5 milligram because the 0.75 milligram is only indicated for monotherapy use. So, overall, we saw reductions in A1C and in weight, primarily over a 40-week period. It was a randomized clinical trial that spanned 40 weeks. Anyways, we used the patient characteristics from SUSTAIN 7, also the treatment effects, the adverse events, etc., to populate in the model, and then we ran the model for a 3-year treatment period on both semaglutide and dulaglutide before they were then intensified with basal insulin as a rescue medication. We used hypoglycemia rates from the UK hypoglycemia study group. We used the local cost in Denmark to inform the cost of complications. We discounted costs and clinical outcomes with 3% per annum. We also conducted probabilistic sensitivity analysis to explore the uncertainty around the mean, around key parameter assumptions. Overall, the results showed a slightly improvement in QALYs of 0.06 QALY for sema 0.5 milligram and 0.14 QALY for high dose of semaglutide compared to Trulicity or dulaglutide 1.5 milligram. This was this was the result on the basis of a reduction in both micro and macrovascular complications, incidence of those, and also delayed in the onset of those. Also translating into both the improvement in QALYs, but also reduction in the cost of those particular complications. For the low dose of semaglutide, you had overall slightly higher total cost compared to dulaglutide. So here the cost of complications were not entirely offsetting on the higher treatment cost, whereas the case for the high dose of semaglutide, here you had the higher treatment cost, but then they were completely offset by a reduction in micro and macrovascular complications. So overall, you had a dominant position for high dose of semaglutide and then a very cost-effective treatment option with low dose of semaglutide. When we looked at the probabilistic sensitivity analysis, we saw similar results of the mean, but then with a slightly broader variance. In terms of the cost-effectiveness acceptability curve based on a Danish cost-effectiveness threshold of 378,000 kroner per QALY, then this will roughly translate into 60% and 80% probability of being cost-effective in a Danish setting. Yes. Okay.